Thank you, everyone. My name is Tashfiha Nusrat Ruhi. I work at ICDDRB, and today I'm going to present a research that me and my team have conducted to understand the multi-level interlinked factors driving unintended pregnancies among female garment workers. Nothing is more fundamental to bodily autonomy for women than the ability to decide whether or not to become pregnant. And yet, many women in Bangladesh are unable to make this life-altering reproductive choice. We begin by unpacking the operational definition of unintended pregnancy, which states that unintended pregnancies are pregnancies that are reported to have been either unwanted or mistimed. Globally, around 42% of all unintended pregnancies take place. Globally, around 42% of all pregnancies are unintended. However, the rate is much higher in LMICs at 75%. Existing research already links unintended pregnancies with several negative outcomes in maternal and child health, as well as adverse socio and economic outcomes. In Bangladesh, 21% of all unintended pregnancies are unintended according to the BDHS. There is extensive research already that links lack of family planning services and limited contraception use to unintended pregnancies. However, in a patriarchal society like Bangladesh, gender inequalities dictate autonomy of women and their agency. Our study has two main objectives. First, to measure the lifetime prevalence of unintended pregnancy, and second, to utilize the socio-ecological model to understand the interrelated drivers across multiple levels, that is, individual, interpersonal, institutional, and community. In our methods, we used the first round of longitudinal cohort data of female garment workers aged 15 to 27 for both quantitative and qualitative data collection in 3 slums covered by ICDDRB's Urban Health and Demographic Surveillance System. Our survey sample included 656 currently married female garment workers, and our qualitative data included 40 in-depth interviews and 9 key informant interviews. So this is our inductive thematic analysis. So we conducted this inductive thematic analysis under these overarching themes and sub-themes, ranging from individual characteristics, family planning practice and belief, influence of key actors, occupational factors, and finally, norms and regulations that constrain individual behavior. Results. We estimated the lifetime prevalence of unintended pregnancies among our quantitative sample to be 43%. We also identified 17 cases of unintended pregnancies from our qualitative sample of 40 in-depth interviews. So these 17 cases came from 11 women who had multiple unintended pregnancy. So if you look at the key background characteristics of 11 respondents, you see that almost all female garment workers had child marriage and most of them had adolescent pregnancy. The findings of thematic analysis at individual level state that many women mention lack of adequate knowledge, irregular use of contraception, and perceived side effects of contraception as main FP-related, family planning-related factors that contributed to unintended pregnancies. During one KIA, a doctor mentioned how mismanagement of contraception use is tied to the lack of adequate knowledge and how different contraception methods work based on how they're maintained. So young age during marriage was another important socio-demographic factor that increased the likelihood of unintended pregnancies. Most female garment workers expressed personal belief on traditional gender roles of SRHR. Therefore, husband's role in the family was greater than their own, and therefore they were also the supreme decision maker regarding women's reproductive choices. At interpersonal level, we saw that husbands' attitude, belief, and role had the strongest influence on contraception use. Most husbands expressed gender inequitable views that restricted women to communicate and negotiate regarding their reproductive choices. We identified unequal negotiating power as well regarding women expressing their fertility preferences, as majority of women had low or no level of couple communication and negotiation. Husbands believed that wives should have increased burden of maintaining contraception. But when it came to decision-making and obtaining the method of contraception, husband was the main role. husband played the main role. We also saw influence of in-laws and extended family in women's reproductive choices. At institutional level, respondents cited their long hours of work caused disruptions to maintain contraception as well as maintain a communication with their spouse. We also saw that they faced challenges for family planning to access family planning services within the factory as well as outside because they had to work long hours. Social expectations such as proving fertility after marriage was another driving norm that influenced our study population. And at the same time, we saw that gender norms restricted women to make their decisions. In our discussions, we see that contraception is key, but simply providing contraception is not enough. Gender-related barriers existed across different levels of socio-ecological model that prevented women from exercising their rights to communicate, access, and use family planning-based services on their fertility preferences. We saw power imbalance within the relationship, and that therefore favored husbands' fertility choices as they had more patriarchal beliefs and masculine traits. This also supports the previous findings in LMIC context, which reveal that targeting women for family planning services is not enough. We have to include husbands who are responsible for controlling women's reproductive choices. And finally, we make some brief recommendations from our study, that is, comprehensive family planning services should be introduced in the factory to increase accessibility for female garment workers. We need to target motivations that influence the male partner to improve spousal communication and promote collaborative decision making. And finally, a strong focus needs to be there on equity and gender transformative approaches so that we can address harmful social norms by reaching key actors who influence women's decisions in reproductive health. Thank you so much. I'd like to thank my team, and please, any questions?